Hello, good afternoon, everyone. My name is Benzie. I am the Fellows Chair of the Subcommittee for the SSAT Complex GI Surgery Fellows Program, and we have a great talk tonight. I'm very excited to introduce Dr. Leah Qureshi, who has graciously agreed to be our moderator. She is Associate Professor in the Department of Surgery, a minimally invasive gastric and esophageal surgeon at Oregon Health and Sciences University in Portland, as well as the Chair of Women in ISDE. And Dr. Qureshi, if you wouldn't mind just introducing us and giving an overview of the beginning of our session.
Yes, thank you very much, Dr. Benzie. So we're here today, and I would like to thank SSAT and the coordinators for the opportunity to present tips and tricks for Ivor Lewis esophagectomy by Dr. Chelsea Yap, who is Advanced GI Fellow at the University of Florida, Jacksonville, and her mentor is Dr. Ziad Awad. And I've seen her talk. It should be very exciting and engaging for the group. And we welcome everyone's comments. And Dr. Yap, it's all you.
Thank you, everybody. Thank you to the SSA committee, Dr. Benzie and Dr. Qureshi for your help with the talk. I'm going to be talking, like she said, about a little bit of history and tips and tricks for Ivor Lewis esophagectomy. I don't have any disclosures. My objectives today for the talk are to discuss epidemiology and workup of esophageal cancer, describe historical and current surgical approaches for esophageal cancer, and demonstrate key portions of the minimally invasive Ivor Lewis esophagectomy, including creation of our gastric conduit, the abdominal lymph node dissection, thoracic lymph node dissection, and creation of an intrathoracic anastomosis. So a little about epidemiology. Esophagogastric junction cancers are among one of the most frequent diagnosed cancers in the world and seventh leading cause of cancer-related deaths in America. That's coming after lung, breast, colorectal, prostate, stomach, and liver. The highest incidence around the world are something called the esophageal cancer belt. These are the regions of South Central Asia, northern portions of Iran, southern Russia, and northern China. Here's where we would see higher rates of squamous cell carcinoma of the esophagus, and then less frequently diagnosed in North America. It's actually the 14th most frequently diagnosed cancer here, and as I'll say later, more commonly adenocarcinoma. Just some estimates here from the American Cancer Society for 2025 in the US. This year, estimated about 22,000 new cases of esophageal cancer, more common in men than women. So about 4 out of 5 esophageal cancer diagnoses occur in men. And only 1% of new cancer cases in the United States are esophageal cancer, which I found pretty interesting because, of course, at my center, we do a lot of esophagectomies, but it's interesting that it really is only about 1%. This is an important slide to classify the different types of esophageal cancer. So 2 main types that we're looking at here, the squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is more commonly found in the upper and middle esophagus, while adenocarcinoma is more commonly found in the lower esophagus, more towards the GE junction. Risk factors for squamous cell carcinoma include things like smoking, alcohol, and adenocarcinoma risk factors are things like obesity, Barrett's esophagus, reflux, and smoking as well. And like we said, squamous cell carcinoma is more common in Eastern Europe and Asia, while adenocarcinoma is more common in North America and Western Europe. So I don't want to spend too much time on the surgical history, but I went down a little bit of a rabbit hole when I was doing this presentation, found some really interesting things about surgery in general and specifically the esophagectomy. So I'll go through this a little bit. Hopefully you find it interesting as well. So in 1913 in New York City, Frank Turek performed the first esophageal resection that demonstrated feasibility for transthoracic esophagectomy. This was actually for squamous cell carcinoma of the esophagus. He performed a wide left posterior lateral thoracotomy. There was no continuity established here, just the esophagectomy portion. He made an esophagostomy in the neck and a gastrotomy in the tube. Gastrostomy was placed in the stomach. And this patient had an extrathoracic rubber tube placed on post-op day 8 for feeds. And the never actually got reconstructed. And she actually lived for 12 years and died from a pneumonia later on. This is something that I never really thought about as with the esophagectomy, even not having like continuity being established. So of course, in 1913, this was not the priority. In 1914, Wolfgang Denk describes the abdominal and cervical approach to an esophagectomy on cadavers. And this is something that I found interesting that with the invention of the mechanical staplers, this really transformed surgery in general and also the esophagectomy. This first stapler, though, was actually quite heavy, 3.5 kilograms, so almost 8 pounds, very difficult to load and sterilize and handle. So just thought that it was interesting to think about how the advances in technology, anesthesia, and like postoperative care were all things that helped the esophagectomy kind of get where it was today. As I said, primary goal would be resection. Very few people were getting reconstructed, and the conduits used at the time were either stomach, jejunum, colon, or skin. In 1933, Gray Turner reintroduced the pull-through method that Dr. Dank was doing on cadavers, and he performed the first esophagectomy with successful continuity 2 months post-op with the conduit of jejunum and skin. And here's Dr. Gray Turner. And then Dr. Ivor Lewis here, he was a surgical resident in London in the 1920s. He performed the first Ivor Lewis esophagectomy in 1944, and it was actually a two-stage procedure where he performed the abdominal portion at one time and 2 weeks later the thoracic portion. And surgeon Norman Tanner published a one-stage esophagectomy 9 months later. And then just some other advances surgically that helped transform the esophagectomy. Dr. Richard Sweet demonstrated that division of short gastric arteries would still have a viable stomach that could be used and mobilized. The Cochrane maneuver, and it demonstrated that there was more feasibility. A cervical anastomosis feasible and gaining more length on the conduit. And then in the 1990s is when we start to see more of a minimally invasive approach. In 1992, Alfred Kucheri performed the first thoracoscopic transthoracic esophagectomy in the UK. And in 1995, the first completely laparoscopic transhiatal was performed by Dr. Ludovico de Paula in Brazil. In 2002, Melvin et al. Published the first successful robotic-assisted Ivor Lewis esophagectomy. And this is just something that I also found really interesting, that it said that the eyeless needles don't get enough credit because of how traumatic it was here. As you can see, like having this eye here for suturing. So this, now that the needles didn't have eyes on it, it was just something less traumatic for surgery across the board. Just a quick pause here if anybody has any thoughts or anything to add about epidemiology or history.
Yeah, Chelsea, really nice presentation so far. And, the historical perspective, I also find fascinating. And when Thoracic first did his original operation, he found that the patient, so the biggest challenge in the 1900s was that as soon as you opened the chest, it collapsed because there wasn't positive pressure ventilation. It just hadn't evolved until the 1940s. And so there were multiple attempts to do esophagectomy, but as soon as they opened the chest, the patient, of course, died. But in the case of Thoracic, what was really fascinating was when they opened that patient's chest, and it was a woman I forgot her age, but she wasn't that old, but she had tuberculosis. And in hindsight, she had all these adhesions in her chest. And it was those adhesions that, serendipitously held open her chest. And that allowed them to do the esophagectomy. And amazingly, it took them 2 hours to do the entire operation. But like you said, she had everything externalized. And he had the foresight to actually give her a G tube. And that's how he brought out this rubber tube from the neck, esophagostomy, down to a G tube that he'd given her like a week before. So it's actually fascinating that, he was able, and I wonder if any of the audience out there have any questions or thoughts on, I loved your historical perspective. Any takers out there?
I don't have a question, but it's more of a comment. We always talk about esophagectomies and the morbidity of like even now, it just having that conversation with that patient where you try to convince them that this is the thing to do, right, is definitely challenging, I imagine, back then. But the fact that 12 years Like, that's amazing for anything that you do to the esophagus that lasts 12 years, right? You know, that's pretty incredible. So,
Yeah, no, a great point, Annie. And even now, 12 years out, like that's a remarkable feat for post cancer for post cancer esophagectomy. It's really interesting that she survived so long, and she died of what unfortunately is a common complication, right? The morbidity of the lung issues, the aspiration, and that's what a lot of our patients currently have a challenge with as well. So it's a great point.
Dr. Yeah, continue.
So here we are going to go over a case presentation. So PK is a 47-year-old Caucasian male with a past medical history of Barrett's esophagus and GERD, seizure disorder, and hyperlipidemia. He had presented to his PCP with a 2-week history of chest discomfort and reflux, and 3-week history of dysphagia to solids and some liquids, and a 30-pound weight loss. Past surgical history was relevant for an open appendectomy. And social history, he was a 23-pack-year smoker, a quarter pack per day, and did not have any alcohol. He was married, had 2 children, and previously worked in a movie theater. And on physical exam, he didn't have anything remarkable, and his BMI was about 28. So for workup for esophageal cancer, of course, we start with a thorough history and physical. Always want to mention that on any sort of oral board scenarios. Then got a full set of labs. He did have AGD and biopsy, CT chest, abdomen, pelvis, and PET scan and EUS, which we will go through now. On the CT chest, abdomen, pelvis, he had distal esophageal wall thickening, however, no concerns for metastatic disease. On the EGD, he did have a distal esophageal mass at the GE junction extending into the cardia that was ulcerated and circumferential. Pathology showed poorly differentiated adenocarcinoma with mucinous and signet ring cells features. And leads me into next the C-word classification. So there's 3 different types. Type 1 is when your epicenter in the lower esophagus is 1 to 5 centimeters proximal to the esophagogastric junction. Type 2, when the epicenter is within 1 centimeter above or 2 centimeters below the junction. And then type 3, subcardial carcinomas, where the tumor epicenter is between 2 to 5 centimeters below the esophagogastric junction. Type 1 and 2 can be treated with esophagectomy, while type 3 is more treated as gastrectomy, like gastric cancer. Our patient was a type 2 and ultimately underwent an esophagectomy. On the PET scan, patient had increased activity in the distal esophagus and the gastric cardia with an SUV of 4.3. And then the EUS showed a T3 N2 hypoechoic mass at the GE junction and cardia. So to summarize here, we have a 47-year-old male who's fairly healthy with T3 N2 poorly differentiated adenocarcinoma with progressive dysphagia and weight loss. Any thoughts from any other trainees in the crowd on what things we could do next?
Dr. Russo, Dr. Soheim.
And while people are thinking out there, I think you presented this really interesting case, Chelsea. So the signet ring cell, does that make you pause for a minute in terms of pathology and its significance?
It does. Signet ring cell is usually more aggressive and can be not as favorable pathology for patients with cancer.
Yeah, excellent point. And the other thing with signet ring, because it's so aggressive, is that you can have skip lesions. And that's something I have seen in the operating room where you'll have, the GE junction cancer. And then as you're doing your anastomosis and you look at the esophagus, there will be islets of signet ring cells. And so you have to be very careful. This is a very bad actor, in exactly as you said. It's much more aggressive, but it has these skip lesions, and that's something to be aware of. So
our patient with the progressive dysphagia and the weight loss, of course, we discussed him at a multidisciplinary tumor board with our surgical oncologist, radiology, and medical oncology. But due to his weight loss and the dysphagia, he underwent a port placement and a laparoscopic jejunostomy to preoperatively to his esophagectomy. He did undergo neoadjuvant chemo radiation therapy. and on his repeat PET scan had some improvement. Some centers do restaging CT, chest, abdomen, pelvis, as well as a PET scan, as well as some centers perform diagnostic laparoscopy for staging. So there's definitely some variations in staging for esophageal cancer.
The other thing that some surgeons will do at that point is do gastric preconditioning, but I won't belabor that point, at the same time as a feeding tube.
Thank you. Of course, here's for esophageal cancers, TNM staging. Very important because the T stage, end stage all helps guide our next steps in therapy. So important here, starting with like T stage in situ, is high-grade dysplasia of just the esophageal epithelium, but confined by the basement membrane. Whereas T1A invades the lamina propria and the muscularis mucosa, and T1B invades the submucosa. T2 invades the muscularis propria, as you can see here. And as I said, our patient had T3 tumor that invaded the adventitia all the way out here to the periesophageal fat, as you can see here. And then T4 is when the tumor invades adjacent structures. T4A invades the pleura, pericardium, azygous vein, diaphragm, or peritoneum, all structures that could be potentially resectable. Whereas T4B, the tumor invades other structures that are unresectable, such as the aorta, vertebral body, or the airway. And then, of course, the regional lymph nodes, the end staging with patients who have 1 or 2 regional lymph nodes is N1 and N2 as well. And then N3, you can see there, 7 or more. And then, of course, for metastases, M0, no distant metastases, and M1 for distant metastases.
That's great, Chelsea, a great review. I think somebody in the chat asked what gastric preconditioning is. And gastric preconditioning, Chelsea, I don't know if you do that and you'd like to answer that question.
I can answer that one. Thank you.
Okay, no, happy to. So gastric preconditioning is a form of really planning ahead and creating, increasing the blood supply for your conduit. And I will often do this for 2 classes of patients, at least that's what the data shows. 2 patients who will benefit are those who are smokers. I believe this gentleman was a smoker, and also diabetics. And really, it's quite simple when you do your diagnostic lap and washings, as I often will for a G junction cancer. You basically take the short gastrics and you take the left gastric. And when you do that, what you end up doing is, just like traffic, you increase the right gastroepiploic blood supply. And the timing is at least 2 weeks apart from your esophagectomy. But I see pretty dramatic responses. And there have been some data that suggests that really lowers your leak rate because of better perfusion. That's gastric preconditioning.
Very interesting. Would that be anytime you're doing like a preoperative J-tube, you would just use the J-tube report and like the preconditioning, or sometimes conditioning without a J-tube?
Yeah, great question. So, it's very selective. So as you know, not every patient needs a J-tube. So sometimes you might just, for a smoker or diabetic, often I will do gastric preconditioning, or in other patients who are, not so healthy or very frail and you're worried about your perfusion. You can do it at any time. It has to be at least 2 weeks before the actual esophagectomy. So it's selective.
And then for surgical management, the NCCN guidelines has good evidence blocks and flow sheets for the next steps in any cancer. So here we can see for the adenocarcinomas, it breaks it up into T1B and T2 low risk lesions. However, we're finding more that across the board with practices, we are with any T2 lesion, whether it's low risk or well differentiated, putting them kind of here in the second category who are undergoing pre-op chemoradiation therapy. For that first class, for T1Bs, that would be an upfront esophagectomy. Our patient had T3, so any T2, T3, or any N nodal disease patient would be in this class, and these patients are undergoing preoperative chemoradiation with a planned esophagectomy, which is what our patient underwent. And then you can just see here through the flow chart, and if they had T4B disease where it was invading unresectable disease, just definitive chemoradiation. Just to briefly touch on the Esophagectomy trial, there's been some advances in the neoadjuvant therapy. The cross trial was previously, and currently what some people are doing, the neoadjuvant chemoradiation therapy and this specific regimen here, the paclitaxel and the carboplatin. However, there is a new trial going on where actually like FLOT therapy is something that's being more change towards. So lots of changes kind of coming with the neoadjuvant therapy. I don't know if Dr. Krish, you wanted to talk about that a little bit.
Sure, happy to, Chelsea. So yeah, the ESOPIC trial came out last May, and some centers have, embraced it very aggressively, including ours. And FLOT is what we use for gastric cancers. It's a very aggressive chemotherapy. So what we've observed is not all patients actually make it through FLOT. And we're seeing slightly different results compared to the data. And FLOT, and this is this regimen is only appropriate for adenocarcinoma. So that's one important distinction. So squamous will still get cross, but if a patient has adenocarcinoma, which of course is much more prevalent in the United States, as it is related to Barrett's and the progression of Barrett's, which is also more prevalent here. They can, depending on your oncologist's preference, they will can undergo FLOT. And so this is evolving. Some centers have taken it on, others have not, but this is a big paradigm shift within esophageal cancer.
Thank you. And then next, so surgical risks. Our patients undergo PFTs and cardiac stress testing, and our patient, this was normal. And then also just some screenshots here of what we go over in the clinic with our patients, their ECOG score, frailty exam, and their NSQIP score. These things are, of course, helpful for the surgeon to risk stratify their patients, but I also find that it's also helpful with the patients to give them something objective and something tangible for them to help set their goals. If we're going to like, hey, if you quit smoking and weight loss and all these different risk factors for them, that I find that this is helpful and the patient to give them a visual. And then our patient underwent a robotic assisted Ivor esophagectomy. And just to go into surgical approaches. So of course, with any surgical approach, we have both open and minimally invasive. And then there's 3 different approaches for an esophagectomy here, the transhiatal, an abdominal approach, and a cervical approach. And then the 3-field, which has the abdominal, thoracic, and cervical approach. And then the Ivor-Lewis, which is abdominal and thoracic. And we'll go in a little bit here. This was a study that looked at a retrospective analysis of over 500 different hospitals, a total of 4,053 patients. They were comparing and contrasting transthoracic esophagectomy versus transhiatal esophagectomy using the NSQIP analysis. What they found was that the transthoracic esophagectomy had a higher incidence of pneumonia and bleeding that required a transfusion. However, the transhiatal had higher incidences of wound infections, unplanned intubations, UTI, and sepsis. But it's important to note that between the 2 different approaches, no survival benefit difference and similar incidence of both anastomotic leak and 30-day mortality. And then this was another meta-analysis of 52 different studies that were all comparing and contrasting transhiatal esophagectomy versus transthoracic, looking at almost 6,000 patients total. Their findings were the transthoracic had longer operative times and length of stay, more respiratory complications, and wound infections. However, the transhiatal esophagectomies had higher leak rates in this specific analysis, stricture, and of course recurrent laryngeal nerve because in the neck. There was, again, no difference in the 5-year survival. With both of these studies, they did not have it broken down into minimally invasive versus open. There are data out there that does show that minimally invasive approach does have shorter length of stay and less morbidity and mortality. And as the data shows, like there's really no right or wrong way to do an esophagectomy. It's really surgeon preference, their training, and there's no difference in survival rate or really esophageal leak overall.
And that's great, Chelsea. And, it's interesting, the transthoracic, unfortunately, they didn't break it down to MIE or not, or open. But one point of consideration, presumably the transhiatal bypassed the chest and had higher bleeding rates, whereas the transthoracic went into the chest and they had, more respiratory complications. And I think that data has been presented well at many meetings. But presumably they also had a higher lymph node extraction rate in the transthoracic approach, which is what one would expect. And I do recall reading some literature that when the transhiatal first came out, in the open transhiatal approach, it's really a very blunt dissection of putting your hand up through the chest, basically blindly. And so it's not surprising to think that you might have, higher rates of bleeding as well as recurrent laryngeal nerve injury. And when I trained as a fellow, which was a while ago now, that's really what it was. You put your hand in blindly all the way up the patient's chest, which is remarkable. I mean, now most of us do it laparoscopically or robotically, and we have, really excellent visualization. But it's really interesting to think about these studies.
Thank you. Now I will go over more specific to our program and how we're doing our approach. So with the abdominal approach, I'm going to show some videos and discuss the creation of the gastric conduit that we do in omental flap, the abdominal lymph node dissection, and creation of a jejunostomy tube, injecting ICG at the root of the mesentery to later identify the thoracic ducts. And then in the thoracic portion, the robotic thoracic lymph node dissection and creation of our anastomosis. Here is a diagram of our port placement. We have a 12 here, and assist 12 up here. We also have an assist port usually right about here next to the umbilicus here, and then a liver retractor. So we start by opening the gastrocolic omentum below the level of the pylorus with quick attention to the origin and the course of the right gastroepiploic vessel, of course. And this, we found that like just below the pylorus is a really thin layer of fat here that helps us really identify the vessel and then mobilize that towards the spleen, as opposed to identifying the vessel more towards the spleen that some other practices do. We then divide the attachments from the proximal transverse colon to the retroperitoneum, exposing the duodenum so that we can perform an extensive cauterization. Then once we've divided the gastrocolic omentum and mobilized the short gastrics towards the left cruce of the diaphragm, some technique here you can do is to make the bed left side up to help not pull so much traction on the stomach. And then dividing the gastrohepatic ligament towards the right cruce and mobilizing the GE junction circumferentially. So here for the ideal gastric conduit, having this along the greater curvature of the stomach. Here it says 4 to 5 centimeters. However, we have been doing like 3.5 to 4 centimeters, making sure there's a uniform diameter and adequate length of the gastric conduit, ensuring that there are no step ups with the staple line and no spiraling of the conduit. So here in this video, we will emphasize that the circumference that we're making for our gastric conduit, about 3.5 to 4 centimeters, and then also the direction of traction that we're pulling on the conduit. So here with robotic arm 4 with the tip up, we're pulling lateral traction here. As we place each staple load, we're ensuring that the staple loads are meeting so that there are no step ups or spiraling of the conduit. And then once you reach about 4.5 centimeters between the gastro and the antrum, what that means, we're going to change on 4 to downward traction. This video is actually, here, as you can see, is robotic. However, currently in our practice, we're doing the creation of the conduit before then after you clear the conduit, you basically need to assess the position of the conduit and then
Chelsea, do you want to just use your headset? You're breaking up a little bit. Yeah, I just want everyone to hear you because you're doing great.
Is this better? Yeah, okay, thank you. Okay, so here we have our abdominal lymph node dissection, and as I was saying that we prefer to do this after we've made the conduit. We find that once we drop the conduit inferiorly, it really exposes the porta and the splenic vessels and helps with our lymph node dissection. Here we're starting to dissect out the station 8A and P lymph nodes here on the common hepatic artery. And then in a little bit, you'll be able to see the portal vein coming up right behind here. So just kind of bluntly dissecting away the tissue. Here you can see the portal vein right here coming up.
What setting is your scissors on, like heat wise?
Usually on 3.
Okay.
You can see that the robot gives really nice visualization of the dissection.
The robot energy is 1, 2, 3, 4. So 3 is like just 1 below the maximum.
And then you can see here, just dissecting this off. And then finally isolating the left gastric artery here. And then we staple the left gastric artery with a vascular load of 45. And then finish taking out the rest of the lymph nodes there. After we've done that, we will suture the conduit to the specimen, and then we place a orientation stitch so that we can see where our anterior conduit is, and then create the jejunostomy, and then we do inject ICG at the root of the mesentery so that in the thoracic portion, you can identify the thoracic duct, which I will show you in a second. Then once we transition to the thoracic portion, we reposition the patient to the left lateral of the cubitus position. Single lung ventilation is achieved with a double lumen ET tube or a bronchial blocker. Once you reposition the patient, you can see this is how we do our port placements here. The scapular line, we have arm 1, and then between that and the posterior axillary line, arm 2, and then arm 3 and 4 here in the posterior axillary line, and then we'll retrieve our specimen through R2. So here is a video of us starting out the robotic thoracic dissection here. You can see we've divided the inferior pulmonary ligament and incised to the level of all the way up to the inferior pulmonary vein. And this helps reflect the right lung anteriorly. You can see the mediastinal pleura is incised, and ultimately the esophagus is circumferentially mobilized for the surrounding lymph nodes. And here we can see this here is the azygous vein, and then lighting up in green is the thoracic duct. That is the reason why we inject the ICG at the root of the mesentery in the abdominal portion. And then dissecting the subcarinal lymph node tissue, this gets taken and blocked with the specimen, and just freeing up the esophagus from the airway. You can see the esophagus is reflected upwards here in the video. And this is you can see the airway right here and here. Then once we have completed the lymph node dissection, we perform the anastomosis. So using a robotic linear stapler, we transect the esophagus. The azygous vein is divided selectively. In this patient, it was not divided. Then we make a aneuratomy here in the esophagus and insert our orbital. Once this is fully exteriorized, we then move the camera to arm 3, and through where arm 2 was, we extend a posterior lateral thoracotomy incision about 4 centimeters and place a wound protector there. So you can see we passed our orbital here, deliver the specimen into the chest. Again, we've already placed an anterior marking stitch to help us maintain orientation of the conduit to ensure that there's no twisting. Deliver the specimen, make a larger incision in where arm 2 was. And then once we've done that, we take out the specimen and then reintroduce the EA stapler. We use the 25 EA through the gastrotomy here. The orbital and the anvil are mated here. And then once we've made the anastomosis, we evaluate our donuts to make sure that we have 2 complete donuts here for the esophagectomy, the gastric donut, and the esophageal donut. We then place the camera back in arm 2, and then using a linear stapler robotically, we transect the gastrotomy site that we use to make the anastomosis. We also bring up an omental flap here and leave that adjacent to the conduit. So postoperatively, all of our patients do go to the surgical ICU. We have a postoperative esophageal resection protocol that we follow. On post-op day 1, our patient had their fully removed, arterial line removed, and we start mineral oil through their J2. The NG tube gets removed on post-op day 2, and then we start their tube feeds on post-op day 3. On post-op day 4, we perform a CT scan with oral contrast to evaluate the anastomosis. On our patient, there was a questionable leak with a small amount of air around the anastomosis, so we actually did an esophagram on day 5 that confirmed that there was no leak. And then ultimately, the patient was discharged on post-op day 13 once home health and all his tube feeds for home were set up. Our patient's final pathology showed residual poorly differentiated carcinoma with signet ring cell features with the largest focus of 1.5 centimeters. The margins were negative, T3N0 disease, and 0 out of 47 lymph nodes were positive for disease. All of our patients have very close follow-up with telephone calls and clinic visits. They're usually seen in clinic within the week, like the next week since they've been discharged. And we have a big multidisciplinary team that makes phone calls to them and very easy for them to reach us if they need anything. And then this patient did follow up with medical oncology for adjuvant immunotherapy. And then we see them about every 3 months for a year, then every 6 months for 2 to 3 years, and then annually after that. And here's some of my resources.
That's great, Chelsea. What an interesting case. One question that comes to mind as you present it. So his esophagram was negative post-op day 6, and yet he was discharged a week later. What kept him in hospital?
Yeah, I looked back in the chart. It looks like there was some problems with his home health, like getting the tube feeds set up. But there were, other than that, he was just there was no complications from the leak that we thought that he had.
Excellent. And I would welcome questions from the audience. And while they are getting those questions ready, one quick question for you in terms of technically, why use the Orville? Why not, you've got the robot there, you've got the dexterity of using, 6 degrees of freedom. Why not do a hand-sewn anastomosis when you're up there?
That is a good question. Again, I think that comes back to surgeon preference, and
Sure.
also I haven't found any data to support like hand sewn versus stapled. So I think that that's why we just keep going with the stapled anastomosis.
That's fair. I think that, that data will come. There are more surgeons doing esophageal resection with robots. I'm sorry, please continue. I didn't realize you had more.
Oh no, sorry, that was it. I was going back to I don't know why
Oh,
I
I
went
see. Okay.
backwards. I'm sorry.
Oh, no, not at all. And we can minimize the slides so then we can see the audience as well and take their questions.
Perfect. And first question in the chat, I had this as well. Could you just elaborate a little bit more on the ICG injection in the root of the mesentery? Because I think that's very, very cool.
Yeah, so I wish I had a video of that. I'm sorry, but we inject like once we've done the J tube and the jejunum is kind of tacked up to the abdominal wall, we're easily able to view the root of mesentery there. And then using the laparoscopic needle, we just inject like 5 cc's like anteriorly on the root that we can see, and then 5 cc's posteriorly. And then by the time we've flipped to the chest, we can see the ICG in the thoracic duct there.
And it's also, yeah, it's great to see the thoracic duct. It really stands out, which is impressive.
And do you do ICG on the conduit as well? Like, do you have anesthesia?
We do, yes.
Lots of green going on, right?
Yeah. But I'm sure it's very reassuring to see it light up.
Beautiful, right? Some of the most beautiful pictures you probably have on your phone. Do you routinely inject Botox or do a pyloroplasty in these patients?
We inject Botox about 20 cc's of Botox.
And in our practice, we actually do a pyloromyotomy. So I'm curious, the Botox. So Botox, as majority, I'm sure, on this call, would worry that it would wear off. So do you see that clinically, or what is your observation?
We haven't. We actually did used to do pyloroplasty, and we switched to doing Botox instead. See, Dr. Watt put his camera on. I don't know if he wants to say so.
So thank you, Chelsea. Hi, Ali. How are you? So this is actually a very, very interesting topic because I don't think the delayed gastric emptying has been very well studied with Botox, without Botox, with pyloroplasty or without. For years, I mean, for 20 years, I was doing pyloroplasty, but then I noticed there's a lot of people are moving away from pyloroplasty, pyloromyotomy into the Botox. And when I spoke to Jose Pimiento, my friend from Moffitt, and he said, "Oh, dude, like we moved away from this a long time ago." Then I made a few inquiries to my colleagues in Europe about the same thing. Having said that, my colleagues from Japan and Korea, they still do pyloroplasty and pyloromyotomy. So I don't know the right answer, to be honest with you.
Yeah, no, and until somebody studies it and gets the data, I don't think we have a great answer. I know that we do pyloromyotomies and have good outcomes. So I think it depends on your practice and what your personal preference is, as Chelsea nicely answered.
And how do you get the insurance approval for the Botox? Is my next question, because I know that's the challenge too.
That's a good question. Just because there is no, so if you look at the code for esophagectomy, I think there are like 8 or 9 codes that come with esophagectomy. That's including EGD, omental flap, jejunostomy tube, lymphadenectomy, abdomen, chest, truncagotomy, blah blah blah. And then, but I don't think we have it built in. Chemical pyloroplasty. I don't think this is built in. But this is a very interesting question because actually I always review some cases from outside and I see people doing chemical or mentioning chemical pyloroplasty. So I assume there's a code for it. Whether the hospital has been reimbursed or not, good question. I don't know the answer.
Interesting, cool. And then the other question I had too is I've never heard of mineral oil in the J tube. Maybe I'm missing something. It's like a trade secret. Could you just elaborate on that?
So
this is actually.
Sorry, go ahead, Dr.
Go ahead, Chelsea. You go ahead.
So my understanding why we do the mineral oil is kind of to keep their bowel regimen, kind of give them something there and make sure that the tube doesn't get clogged.
I think that's awesome. How do you just hook it up to the pump, or do you have the nurses?
They just kind of like push it through it.
Push it through. Interesting. Very
That's
cool.
cool. And how much do you push through?
30 cc's a day.
Oh, every day. So, and this is in place of a bowel regimen like Miralax or something.
Yeah.
Correct.
Cool.
Putting a lot of J tubes. I got to try that out now. Excellent. Anyone else have any questions? Feel free to put yourself off mute. This is a great talk. Definitely amazing dissection videos. Very cool to watch.
The other point that came up while we're waiting for questions that Chelsea and I chatted about is conduit width. And that's an area of some discussion for surgeons who do this operation. And, I was recently at a conference where we asked this question, and the majority of surgeons do narrow conduits, and that's based on anastomotic leak rate and also stricture formation, as well as gastric emptying. And so narrow would be considered less than 3 centimeters, and we kind of belong to that school of thought. But again, there are others who would say that wider conduits, so 3 to 5 centimeters, as Chelsea presented here, that leads to better perfusion and therefore decreased rate of stricture. So it's really interesting. The data is a little bit all over the place. So again, until somebody does that study, we don't really know, but that was a really interesting observation as well, Chelsea, and we chatted about it a bit.
Excellent. Perfect. Well, thank you very much, everyone, for joining us tonight. If you could just put your cameras on for a brief second. Dr. Crushy is also nice enough to post in our chat the DDW QR code. So please, if you haven't already signed up already, the program is now out. So take a look at that. There's really some very interesting talks. So you still have a little bit of time, about 6 weeks to go. So there's plenty of time to get signed up for DDW. I will be there as well. Dr. Crushy, I'm assuming you're going too. So
Yeah.
It'd be great just to see everyone in person. Hopefully get some sunshine on the West Coast.
Would love to see everybody there. I think it's going to be a great meeting. And you can come up to any and all of us to have a discussion about esophagectomy. We love it.
Excellent. And just stay tuned. April 14th is our next grand round. The topic is novel techniques in bariatric surgery, so like SATI, endoscopic sleeves. So we definitely have a little foregut theme going for this grand round series, which I love. And if you all wouldn't mind smiling in about 2 seconds. Ready? 1, 2, 3. Good. It's our picture for Twitter, just so we have it. Let me make sure. Oh, 1 second. Let me do a new one. So my own eyes closed. Ready? 1, 2, 3. Good. Excellent. Thank you all so much. Have a great night. Thank you, Dr. Crushy. Thank you, Dr. Yap. Thank you, Dr. Awad.
Thank you.
Thank you, Dr.
Thank you very much. Thank you. Thank you, guys. Good night.
Thank you, Dr. Yap.
You're welcome to Photoshop my photo.
Sometimes I do that, not gonna lie.
Awesome. Thank you.
Take care.
Bye.
Bye-bye.
Thank you, Dr. Qureshi. Thank you, Dr. Menzie.
Oh, Dr. Yap, excellent job. Very well done.
Thank you so much.
For
I
preparing.
appreciate your help. Thank you.